Okay. So thanks for joining us this morning, everyone. I want to greet you all and give you all a hearty good morning and welcome to our press conference to release the 2022 Cancer in Iowa report. My name is Mitch Overton, and I'm from the Communications Office at the University of Iowa College of Public Health. Every year, this report is compiled by the Iowa Cancer Registry and the State Health Registry of Iowa, based at the UI College of Public Health. So in addition to the data about the projected number of cancer cases in Iowa, this year's report highlights the importance of cancer screenings to detect the disease early when treatment is likely to be more successful. Today, we have 5 panelists to talk about the numbers and discuss the importance and effectiveness of regular cancer screenings. We have Dr. Mary Charlton, Associate Professor of Epidemiology and Director of the State Health Registry of Iowa, the Iowa Cancer Registry at the UI. We have Dr. George Weiner, Director of the University of Iowa Holden Comprehensive Cancer Center, Dr. Andrew Nish, Director of the John Stoddard Center in Des Moines, and Dr. Richard Deming, Director of Mercy One Richard Deming Cancer Center. We also have Lindsay Schmoss, a breast cancer survivor and screening advocate. Each of our panelists will have about 5 minutes for their comments, then we'll open things up for a question and answer afterwards. I can also provide links to the press release about the report and the full report in chat. So we'll go ahead then and get things started. I'm going to turn things over to Dr. Mary Charlton.
Thanks, Mitch. As Mitch said, each year the Iowa Cancer Registry releases a report projecting the numbers of new cancer cases and cancer deaths among Iowans based on our registry data and on death certificate data provided by the Iowa Department of Public Health. We produce this report each year to help public health practitioners, providers, researchers, and others to understand and reduce the burden of cancer in Iowa by tracking progress and determining areas of need. We estimate there will be 20,000 new cancers diagnosed among Iowans this year, up just over 1,000 from last year. Breast, prostate, lung, and colorectal cancers make up about half of all cancer cases in Iowa. We estimate there will be approximately 6,300 cancer deaths among Iowans in 2022. Lung cancer continues to be the most common cause of cancer death for both males and females, accounting for 1 out of every 4 cancer deaths in Iowa. Colorectal cancer is the second most common cause of deaths, and pancreatic cancer is the third most common. These 3 cancers plus breast and prostate cancers account for half of all cancer deaths in Iowa. The report also includes estimates of the numbers of cancer survivors in Iowa. We estimate that there are almost 160,000 people living in Iowa who have been diagnosed with cancer at some point since 1973, when the Iowa Cancer Registry began collecting data. Those previously diagnosed with breast, prostate, and colorectal cancers account for half of all cancer survivors in Iowa. This year, the cancer report focuses on the importance of cancer screening. When COVID-19 was declared a global pandemic on March 11, 2020, almost exactly 2 years ago, many healthcare services were put on hold, resulting in a drop in cancer screening rates. While we do not yet know the extent of the impact of this decrease, it is possible that the missed screenings during the pandemic led to delayed diagnoses of cancer, more advanced stage of disease at the time of diagnosis, and an increase in avoidable cancer deaths. Healthcare facilities have since returned to offering cancer screenings with safety precautions in place. And our goal with this year's report is to inspire anyone who may have missed or delayed cancer screenings to talk to their doctor about getting back on track. We would also like to encourage healthcare providers to strongly recommend screening for those who are eligible. I would briefly like to share some key points from the report. Colorectal, cervical, breast, and lung cancers are all common cancers for which there are United States Preventative Services Task Force recommended screening tests. Regular screening for these cancers is very important, as is follow-up for any abnormal screening results. In the report, we provide information about each of these cancers. For example, about 2/3 of colorectal cancer deaths in the US could be prevented through screening. The percent of eligible Iowans getting screened has not yet reached the National Colorectal Cancer Roundtable goal of 80%, and we are behind neighboring states like Minnesota and Wisconsin. And eligibility guidelines have recently changed to include those 45 years old and older. Nearly all cases of cervical cancer could be eliminated through screening and through HPV vaccination. Unfortunately, in Iowa, we are seeing screening rates falling while the rate of new cases is increasing. In other words, we are going in the wrong direction. While the rate of new cases of breast cancer has been increasing over the last several years, The rate of breast cancer deaths has declined over the same period, at least in part due to an increased number of people diagnosed at earlier stages thanks to screening mammography. And finally, only 1 in 4 lung cancer cases are diagnosed at an early stage in Iowa when the cancer is most treatable. Lung cancer screening is now widely available across Iowa, and guidelines for lung cancer screening have recently changed to include people ages 50 to 80 years old with a 20-pack year or greater smoking history. Getting Iowans back on track with screening is such an important issue that the directors of Iowa's 3 largest cancer centers have all gathered here today to help raise awareness of this issue and share the experiences of their cancer centers and getting Iowans back to screening. And we also have a breast cancer survivor with us who is eager to talk about how cancer screening saved her life.
Terrific. Thank you, Mary. We'll toss things over to Dr. George Weiner.
Thank you, Mitch. Thank you, Mary. And, you know, the pandemic really has brought to the fore the importance of cancer screening because, in fact, many people have put off cancer screening. And it does raise major concerns that because of this, cancers will be diagnosed at a more advanced stage, and as Mary said, at a point where they're much harder to treat. Cancer screening is an important part of the federal government's, as well as the state, efforts to try to reduce the burden of cancer. And in fact, was a primary point of topic in the moonshot that President Biden has recently re-announced. And in fact, the President's Cancer Panel has identified 4 pillars that they believe is necessary to close the gap in cancer screening. And I'd like to talk about those briefly. The first is to improve and align communication about screening. I think we all have experienced where minor changes or differences in opinion in recommendations, such as the precise age where a certain screening should be started, can result in confusion, and that the overall message about the importance of screening can be lost when these minor changes are made based on new data. So it is vital moving forward that the public and healthcare providers alike have accurate information and share that information in a way that's digestible and actionable on the part of healthcare providers and patients so that people do get the screening that they need. The second pillar is to facilitate equitable access. One of the things we've learned from the pandemic is that there are some groups who have limited access to healthcare in general and cancer screening in particular. And these groups are particularly impacted by things such as the pandemic. These lower rates of cancer screening, initiation and follow-up are seen in Iowa among inner city minorities and among rural underserved. And we need to develop better ways to provide access of these populations to the cancer screening that they need. The third pillar is to strengthen collaborations. Team-based medical care in general and cancer care in particular really has the ability to improve cancer screening. And so we need to work together. This includes nurses, PAs, physicians of multiple specialties, pharmacists, and many others who can help share the important message about cancer screening to patients. And then finally, the fourth pillar, which in some ways ties all of these others together, is to create effective healthcare information technology. Systems such as MyChart that we have here at the university and other systems that other medical centers use. These healthcare information technology approaches have the potential to do even more than they're doing now to help providers, patients, and others understand the importance of cancer screening, and also include some of the situations where there's a need for shared decision-making, where the healthcare provider and the patient need to sit down together and decide what screening is right for that individual patient based on their own life circumstances. And effective healthcare information technology systems can help with these areas. So these are our 4 pillars of enhancing, of approaches to closing the gap in cancer screening that are put forth at the national level, but I think statewide and regionally are also important as well. And I look forward to discussion after the presentations about what we can do together to enhance each of these.
Terrific. Thank you, George. Just as a note to everyone, I did put in chat, I put a link to the news release about the report and a link to the full report itself, which you can download at your convenience. Next up, we have Dr. Andrew Nish. Andrew.
Good morning, and thanks everyone for being here. So I'm going to just talk a little bit about what we did at the John Stoddard Cancer Center as far as trying to improve screening rates. And we participated in the Return to Screening project, which was a cooperative project between the NCCN, the American Cancer Society, the COC. And what it was is we got together, it's a nationwide project, and it was really looking at how do we get people back to their routine screenings, because there was a dramatic decrease. Mary said March 11th, 2020, we declared the pandemic, and screening rates plummeted. I mean, they were down as much as 90%, depending on which screening you were talking about. And they slowly began to improve over time. But what this project really was trying to do is help identify mechanisms to get the message out that people need to get back to screenings, that screenings were safe. We were able to protect people through masks and social distancing and things like that, and that the risk of not screening was far riskier than the risk of getting COVID from a screening test. So we looked at our data from the way it was prescribed. We looked at our screening data September of 2019, January of 2020. So that's pre-pandemic. And then during the pandemic, we looked at our data September of 2020 and January of 2021. And then our goal was to improve screening back to pre-pandemic levels. Well, we found during the pandemic that we actually were at pre-pandemic levels. So our goal was to increase screening by 10%. And so what we did is we implemented a program that was a multi-pronged approach. We worked with our primary care providers to improve physician and primary care clinic communication to patients about screening. So patients were sent emails, patients were sent letters, patients were sent notifications in their MyChart that, it's time for screening. And we were particularly interested in getting those patients back who we saw missed screenings. So actual phone calls were made to those patients. We did a lot of patient education. We had brochures in the clinic about the safety of getting back to screening. We did a lot of media education. So we were on social media, getting people back to screening. We did, I have a podcast where we talked about screening. We did some public service announcements through social media about screening. We did radio and TV spots about screening. And we featured it on our website and did all kinds of social media type of things to get that word out. And then I also did an educational event for our primary care providers about screening, particularly with the changes in screening. So Mary mentioned that we did have a significant change in lung cancer screening. We also had a significant change in colon cancer screening, where we dropped the age for average risk people from 50 to 45. So we wanted to educate our primary care providers about that. We worked within our community to try and provide access to lower socioeconomic people because not only are they screened at a lower rate, but they also have higher risks for these cancers and frankly don't do as well with treatment. So that was very important for our program as well. So what we did then is it was prescribed. We kept track of our screening rate from April of 2021 through November of 2021. And what we found is after we did this project, we did improve our screening rates. We didn't reach the 10% in a couple areas, but we did improve screening rates from pre-pandemic levels. So our breast cancer screening rate went up about 3%. Our lung cancer screening rate went up about 5%. And quite dramatically, our colorectal screening percentage went up 31% from pre-pandemic levels. So this just highlights the importance of getting this word out, not only to society in general, but through our primary care providers. And so we consider this, we were successful in improving screening rates. One of the things, and I talked to Mary earlier about this, is many of you may know I'm all about prevention. And when you look at these top cancers, when you look at lung, prostate, breast, colon, pancreas, these are lifestyle cancers. And so I don't want to lose fact that screening is very important to detect cancers early. But what may be more important is how do we change our lifestyles to actually prevent these cancers from ever happening? And that starts with, how do we eat and how do we manage our stressful lives? How do we sleep? And all these things are incredibly important at preventing these cancers. So tobacco still accounts for a large percentage of cancers, whether it be lung cancer, whether it be larynx cancer, esophagus cancer, et cetera. We still have to work on tobacco. About 14% of people continue to smoke or use tobacco products. We know that many of these cancers, particularly colon, postmenopausal breast, these are metabolically driven cancers. These are obesity driven cancers. So how do we work within our society to improve our food offerings to try and help reduce this sea of metabolic dysfunction in our society, to improve patients' ability to not begin to get these cancers? So I don't want to lose sight of that's incredibly important as well. And that's what we did at Stoddard. We were very happy with our results. We had like 37 different interventions during the 6 months of intervention time, and felt that we got the message out, and we continue to emphasize screening. We continue to work with our primary care providers to get patients back into their normal screening protocols. Thank you very much.
Terrific. Thanks, Andy. Now we'll move along to Dr. Richard Deming.
Morning, everyone. Thanks for being here. First and foremost, cancer screening saves lives. This is evidence proven that we actually save lives by doing cancer screening. It's estimated that with the dip in cancer screening that occurred with the COVID pandemic, that we may see over 10,000 excess deaths due to breast cancer and colorectal cancer just because of the loss of early screening. Andy makes a good point, though. It's not just about screening. When we want to reduce the burden of cancer, and you look even at President Biden's reinvigoration of the moonshot, first is prevention. Over 50% of cancers are caused by modifiable risk factors: tobacco, physical activity, obesity, diet. And unfortunately, not only did we decrease screening, but many people took a step back in their fitness programs as gyms were closed. Just a report on the increased amount of alcohol consumption and loss of physical activity that happened during the pandemic. So it was a bit of a double whammy. Not only did people stop going in for screening, but people also, on average, led a lifestyle that was not conducive to preventing cancers. Another point in preventing cancers that Mary touched on, and I think is particularly relevant as we start talking about vaccines, is cervix cancer. 100% of cervix cancers are caused by HPV virus. We can prevent cervix cancer and 4 other cancers that are caused by the HPV virus, and that's by getting the HPV vaccine. I'm really concerned about where we are with conversations about vaccines. Prior to COVID and the COVID vaccine, vaccinations were not politicized. People were going in, and for the most part, children were getting the vaccines at the appropriate time. I am concerned that all of the political discussion around the COVID vaccine is going to spill over to some of our other vaccines. So HPV vaccination is a very important component of preventing cancers. Now, to get back to the discussion of screening, at Mercy Cancer Center, we're also engaged in the same nationwide study that Andy reported on at Unity Point Stoddard. It's jointly done by the American Cancer Society, the Commission on Cancer, and the National Accreditation Program for Breast Cancer. And it is a nationwide program to help community cancer centers around the country boost the screening rate. I'm happy to say that when we looked at our numbers, like everyone in the country, in March and April of 2020, we had a brisk reduction in screening. When we looked at our numbers after March and April, we got back to screening very, very, very quickly. We did the same sorts of programs that Andy mentioned at the Unity Point. There was a lot of social media activity, a lot of education of the primary care providers, where actually screening rests, and a lot of direct communication to patients. In June of 2020, we actually doubled our lung cancer screening over what it had been the previous months. And even during the pandemic in 2020, we increased our screening rate for lung cancer. And in 2021, we actually had a 20% increase in our lung cancer screening. So how did we do it? In addition to all the social media and the education, we also relied heavily on navigators. So navigators are nurses and other healthcare professionals that we particularly assign the screening function to. So for example, in lung cancer, we have a very robust lung cancer screening, and we are in communication with primary care physicians and also other physicians who may see patients who are at higher risk for lung cancer because of a smoking history. That screening is a low dose CT scan of the chest. We had been building on that before the pandemic, and even with the pandemic, year over year, our numbers increased. And as I said, in 2021, they were up by 20%. Another important issue about screening and about cancer treatment is equity. As Andy pointed out, and George pointed out as well, people do not get equal access to healthcare. Screening rates are disparate, and the actual cure of cancer stage by stage is less for individuals of certain socioeconomic groups. So one of the things that we have done is focus specifically on some of those barriers related to the vulnerable populations. So we were able to acquire a grant from the American Cancer Society and from the Iowa Cancer Consortium to address travel concerns, so some vouchers to help improve and provide travel, and then also rely on the Iowa Department of Public Health breast and cervical cancer screening program, the Care for Yourself, which is specifically a safety net program for those most vulnerable populations to allow for screening of breast cancer and cervix cancer, and also the treatment. So in the world of cancer control, it's about preventing cancers that can be prevented. It's about finding at an early stage cancers that you can screen for before they're symptomatic, and it's about access for care. And the whole process from beginning to end has to be looked at with the lens of equity. Are we doing enough to make sure that those underrepresented populations are getting the prevention measures, the screening measures, and also access to care?
Terrific. Thank you, Dr. Deming. And finally, but definitely not least, we have Lindsay Schmoss, who is a breast cancer survivor and is an advocate for all sorts of cancer screening. So welcome, Lindsay.
Thank you. Thank you, Mitch. And thank you for the opportunity to speak with you all today. It is really an honor to be here. I'm in awe of the company that I share with the physicians that I'm speaking with today. I'm just such an honor to be here, and I'm in awe of the company I share today. I do want to let everyone know I am just 1 week out from major surgery. Last Monday, I had my second stage reconstruction surgery. So I'm still on some heavy pain medication. So I'm hoping everything that I say today makes sense. But thankful for the modern era that we're in with pain medication. Last week was rough, but I'm doing much better today. And it's my pleasure to be here to talk with you about screening and early detection. Early detection 100% saved my life. And that's why I'm excited to be here today to share my story with you. My story begins last summer at the end of July 2021. At the end of July, I turned 40. And just about 2 weeks later, on August 11th, I went in for my very first mammogram. I only went in because that's what you're supposed to do as a woman when you turn 40. I had no symptoms, no lumps, no bumps, no family history of any kind of cancer, actually, on either side of my family. I had been feeling great. I was healthy, was looking forward to taking 40 by storm. It has been quite a storm, but not the kind that I envisioned. The day after my mammogram, I received the dreaded callback. And then the following day, on Friday, August 13th, I'll never forget it. It was Friday the 13th. To my complete and utter shock and disbelief, I was diagnosed with breast cancer. And my world was turned upside down in a single moment. The news was debilitating, extremely traumatic. The faces of my 6-year-old son and then 2-year-old daughter were flashing across my mind. I kept thinking, how could this be happening? You know, I'm young, I'm healthy, I have no family history. It's my very first mammogram. You know, how does this happen? But thankfully, due to that mammogram, we caught the cancer early at stage 1A. But the A meaning that it was invasive and it had already started to spread. And so we needed to move quickly. So fast forward to 6 weeks later, after multiple appointments with medical oncologists, radiological oncologists, surgical oncologists, genetic counselors, and other physicians, I was having a necessary double mastectomy. In the beginning of this process, I naively thought that I could have a simple lumpectomy and radiation, like many other women in my life that I knew I had done. But as my surgeon said, my cancer was everywhere. And there was so much that she needed to take out that by the time she took it all out, there would be nothing left to salvage. The idea of a double mastectomy terrified me. I could hardly process the idea of it, but I knew that it was necessary to save my life. And I had a lot to live for. I had 2 little kids. I am so grateful that I was blessed with the best medical care team, including Dr. Deming, who you heard from just moments ago. He was actually the first cancer physician that I saw in my journey. He was so compassionate and caring and set me up on the best path for success. So thank you again, Dr. Deming. Shortly after surgery and recovery, I was at a follow-up appointment with another amazing cancer physician, my surgical oncologist, the amazing Dr. Beck. I was at a follow-up appointment with her, and I was thanking her and telling her, you know, thank you for saving my life. Your hands inside of my body during that surgery, removing the cancer, you literally saved my life. Your hands were inside of me taking that cancer out, and you saved my life. And thank you for that. Thank you for saving my life. And she looked right at me and she replied to me and she said, no, Lindsay, you saved your own life. You saved your own life by getting that mammogram. And I thought, wow, that was a very powerful moment for me. And she was right. That mammogram did save my life. The type of cancer that I had was invasive. And my doctors had told me repeatedly that if I had waited even 6 months to go in for that first mammogram after turning 40, which, you know, in reality would have been a somewhat normal or reasonable amount of time to get your first mammogram when, you know, you just turned 40 and you're healthy and you have no family history and we all live busy lives. And, you know, that could have been a reasonable amount of time. But if I had waited even 6 months after turning 40 to get that mammogram, my doctors told me we would be having a much different conversation today. That's how invasive it was and how fast it was starting to spread. We'd be having a much different conversation right now. So this makes me think a lot about the recommended age to start getting mammograms. As we know, different sources recommend different ages, with some sources recommending women starting between ages 45 to 50. Women are eligible at 40, but some sources say eligible but optional. And the strongly recommended age isn't until 45 to 50. This is very hard for me to think about. If I had waited until 45 instead of 40, I would definitely have been stage 4 and terminal. That word's hard for me to even say as a mom of 2 little kids. Now, I most likely would have developed symptoms or felt a lump prior to 45 and been diagnosed before then. But the cancer would have been at a later stage and more difficult to treat, and my survival not guaranteed. And for me, that's terrifying to think about. And so I'm so thankful that I didn't wait and that I did go in right after turning 40. And so I do strongly encourage women to talk to their doctor and discuss when is the right time for them to start mammography screening. And even if the source their doctor uses recommends starting at age 45 to 50 to start mammography screening, still consider starting at 40 when you're optional, but still eligible. Still consider screening at the earliest possible time. And even if you have no signs or symptoms, get screened, and not just mammograms, but other recommended screenings too. And in future years, get your screenings when they're due and don't delay. Early detection saves lives. I'm a walking example of that. I never thought in a million years I would be diagnosed with cancer. Never, ever would have imagined this would happen to me. I'm so thankful that I got screened when I did, and so grateful for early detection. It's because of that mammogram that I get to watch my kids grow up. Thank you.
Thank you, Lindsay. Thanks for sharing your story. That's really important to hear. And appreciate you being here today to share it with us. We'll go ahead and open up things now for a little question and answer session. If you have a question, please go ahead and unmute yourself and tell us your name and where you're from.
This is Tony Lace from the Des Moines Register. I have a couple of quick minor questions. Lindsay, what town are you from?
I am from Waukee.
Thank you. And then on the registry, can you explain which skin cancers are included in those statistics and which aren't?
Sure. Melanoma would be the main skin cancer that we track at the registry, given its potential for mortality. We do not collect the more minor basal or squamous cell skin cancers or anything non-melanotic. We do not capture.
Thank you.
Thanks, Tony. Yeah, and just a reminder too that in the chat, there's a link to the press release as well as the PDF of the full 2022 Cancer and IRA report if you want to go ahead and download that at your convenience. Other questions for our panelists today? Feel free to speak up or pop something in chat if that's more convenient for you.
Hi, Mitch. I have a question.
Yeah, go ahead, Kelly.
Hi, everybody. My name is Kelly Sittig. I'm with the Iowa Cancer Consortium. Thanks so much for your words and the great report. And Lindsay, a special thank you to you for your just wonderful, inspiring story. Thank you so much. My question is, because we're talking about screening and we talked a little bit too about physical activity and nutrition, there's obviously a really big emphasis on individual responsibility. There are things that we can all do to reduce our own risk of cancer. I wonder if folks today also would be willing to comment or have any comment on potentially the role of things like policy and systems change and how that plays into screening rates and even things like physical activity and nutrition as it relates to cancer risk.
Yeah, this is Dick Deming. A couple things. So Kelly, obviously in policy, we continue to work for tobacco control. I was just up at the State House this last week advocating for continued funding of our tobacco control program. I would say that also when you look at the role of physical activity and nutrition, that being able to provide individuals, so at Mercy Cancer Center, we have a very robust cancer survivorship program, bringing people into the gym, bringing people into spin class, nutrition counseling. Not all of those services are covered. And being able to provide through philanthropy some of those services has been important to help promote physical activity, weight reduction, counseling, and we continue to work to fund those programs that exist, continue to fund the breast and cervical cancer program, but also looking at other opportunities to fund things in the world of wellness, because it's a whole lot less expensive to be able to provide people with the opportunity to be well and prevent cancer than to actually just wait and treat the cancers that come along.
This is George Weiner, and I would certainly second everything Dick has just said. I would also speak about a policy issue, Kelly, as you know, that we've been working on together, and that involves radon. Radon is the second most common preventable cause of lung cancer. It's an odorless gas that occurs naturally and is very, very high in Iowa. And policy approaches to helping people understand about radon, getting their homes tested, getting their homes mitigated, making sure schools are tested for radon is really very important. And it's a policy issue we're dealing with currently. So I wanted to make sure we talked about that as well.
Yeah, this is Andy. You know, Kelly, it was interesting. You talked about personal responsibility, and I want to kind of push back on that a little bit, because, you know, when we're talking about, and I'm going to use metabolic dysregulation as this group, what's going on in 80 to 85% of people in this country, we're becoming more insulin resistant. We're becoming, gaining more weight. We're getting more fatty liver disease. And this is all driven by our food system. And, you know, the food companies would have you believe that it's your responsibility. You know, you're a glutton or a sloth. And this could not be farther from the truth when it comes to food. The food companies have basically hijacked our food system. They have, particularly in underserved communities, you know, you can't get fresh food. And so when you start eating highly processed food, highly sugared food, this is not a personal responsibility thing. This is the food manipulating your hormones and your insulin reaction to these foods and leading to this chronic disease. So I think, you know, we shame people. Oh, you know, it's your fault you're overweight. No, it's the food system's fault. It's our societal system's fault that you can't get well because you don't have the appropriate food environment. You don't have the appropriate environment conducive to physical activity. You don't have the appropriate living conditions where you're not constantly under stress, worrying about how I pay for rent or how I pay for food, or I'm in fear of my life because of the neighborhood I live in. So I really want to remove this. Yes, we all have responsibility for taking care of ourselves, but unfortunately, we have stacked the deck against most Americans because of this lousy processed food system that we have. So, you know, when we shame people, when we say it's your fault, people just sort of give up. And what I try and emphasize with people is, you know, you can change this. You can take this on upon yourself, but you first have to change your environment in which you live in or which you eat in. So that's just my comment on that whole personal responsibility thing.
Thank you. Any other questions from anyone for any of our panelists this morning? Go ahead and unmute yourself and tell us who you are and where you're from. Got a few minutes left here.
Hi, I have a question. My name is Michaela Ram. I'm with the Cedar Rapids Gazette. I just wanted to circle back on the point that was raised about disparities faced by certain groups that affect screening rates. I hoped you could provide some insight to whoever may speak to this on how that plays out for certain racial and ethnic groups. I know last year's report talked about Black Iowans, even though they make up the minority of the population, also die at higher rates. Hoping you could kind of speak to that and how screening rates may play into that issue as well.
Mary, do you maybe want to tackle that one at least to start off with?
Oh, looks like Rich was ready to go, so I'll let Richard go first.
Yeah, go ahead.
This is Dick, and I was just going to say, I don't have those exact data. I think they parallel, but I was hoping Mary might have racial information on the actual screening. As you pointed out, last year's report focused on cancer mortality as it related to various socioeconomic and racial groups.
Yeah, we do see lower screening rates in our Black population. A lot of times it's difficult to get those numbers from the BRFSS given their sampling. Often they don't sample enough diverse communities to be able to keep breaking it down to the level that would be help make it a little bit more actionable. But definitely we see reduced screening rates. We also see like some differences. There's some studies showing that Black people, maybe the threshold for them in developing lung cancer is actually lower compared to white people. So given all the same risk factors, a lower amount of smoking history could lead to lung cancer faster than in a white person. So there's studies going on like that. So there's that also disadvantage. There's some studies showing that in prostate cancer, the type of prostate cancer that Black males get is often appears more aggressive than the type of prostate cancer that white males get. So it's almost just at every level that there's something working against, especially our Black population. And I think really getting the screening rates up in that population is really important. And I think that's what fortunately, a lot of the Iowa Department of Public Health programs are directed at doing, but there's always more to be done there. I think we learned a lot about through COVID that there's some mistrust in the medical system. And I think that we have a lot of work to do there too, to build that trust with our Black communities across Iowa and make sure that they are coming in for those screenings so that we can detect the cancer as early as possible, and then make sure they have access to the state of the art treatment for those cancers so that they have better outcomes, because we just see at every stage that there's a disparity in cancer, and we continue to be in the top few. I think it's us in Wisconsin are typically number 1 and number 2 with the highest Black cancer mortality rates in the country compared to all other states. And that's something, obviously, that's a signal that we need to work at every level to address those disparities.
One thing that we've been doing here in Des Moines with Mercy is to engage the Black community where they're at, to go out to the churches, to go out to some of the sororities, the Black sororities, and to really use our people of color to talk with them. You need to, one of the pushes across the country in cancer healthcare is how do we make sure that those providing healthcare also resemble the populations that we serve? So the whole equity lens goes all the way from the selection of pre-med students and medical students and residents, but also in the community, getting the word out about screening through the communities that we're trying to make sure get equal access to screening.
Great, thank you. Other questions for our panelists this morning? We still have a few minutes left if there are other questions. Okay. Well, we must have done a good job covering all of our bases this morning, gang. No more questions from anyone, so I think we'll go ahead and close out our conference here this morning. I want to give a big shout out and a big thank you to all of our panelists for showing up today, for being here to talk about this important issue. Special thank you to Lindsay for joining us 1 week out from her surgery. We're so glad that you're here today and to share your story with us. So One more plug for the links to the story and to the report are in chat. If anybody else has any questions, in the meantime, feel free to reach out to me. My name is Mitchell Overton. I'm at the University of Iowa College of Public Health. You can find me on email or shoot me a phone call. I'm happy to help out, arrange any other interviews, answer any questions that you may have. So thank you once again to everyone for joining us today. We appreciate you being here and have a terrific rest of your day.
Thank you.
Thanks, everyone.
Thanks, everybody. Bye.
Thank
Sorry.
you. Thanks, Mary.
Yeah, thank you. Sorry for calling you. I was trying to say Mitch, Dick,
Oh, no, no,
Richard,
no.
all at
Oh,
the
no.
same time and think of how I was
No.
going to answer the question.
No problem. Thanks for the opportunity. Have a great day.
Thank
Bye-bye.
you. Bye. Thanks, Mitch, for organizing all this. You're on mute, I think. You talking to me, Mitch? You're on mute.
Sorry, I was. Oh, somebody requested the links, but looks like she's gone. So wonderful. Okay, I think we're good.
All right. Let me know if there's any follow-up that we need to do. Otherwise, I'll see you or I'll talk to you tomorrow.
Yeah, sounds good. Thanks,
All right.
Mary.
Bye. Thanks.
Bye.